Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Today, we're going to take a look at mental health through a global lens provided by Dr. Nasser Loza, an esteemed psychiatrist in Egypt and the UK, with a 360-degree perspective on the field from patient care to policy to global advocacy. Dr. Loza is director of the Behman Hospital, which was built in 1940 by his grandfather, Dr. Benjamin Behman, and the Mahdi Psychology Center in Cairo, and cares for patients there and at the International Clinic London. Internationally, Dr. Loza has worn many hats, including as president of the World Federation for Mental Health from 2021 to 2023, during which time he forged a partnership with Elsevier to amplify World Mental Health Day and release a free Science Direct collection of evidence-based interventions, which was part of an effort to make mental health and well-being for all a global priority. In addition to serving as Secretary General for Mental Health in Egypt, Dr. Loza has chaired both the Middle East Division of the Royal College of Psychiatrists and the Scientific Council of the Arab Board of Medical Specializations. He also serves on editorial boards for the Arab Journal of Psychiatry and the British Journal of Psychiatry, among others. And we're honored to welcome you to Raise the Line today, Dr. Loza. Thanks so much for joining us.
Pleasure.
So with all of our guests, we like to find out about their background and what got them interested in medicine, and in your case, particularly psychiatry.
This is really going back in history. I've done that for over 40 years now. I come from a family of psychiatrists. My grandfather had studied medicine in the UK, came back to Egypt in 1918, and started the very first private psychiatric clinic in this part of the world. And it's been in the family ever since. My father then took it over. But basically, I grew up in a home where psychiatry is what people did. And psychiatry was different 100 years ago. Communication was different. So many of my father's patients would call home on our landline, and he would spend hours on the phone supporting his various clients. And that's how I grew up. So, yes, when I was 10 years old, so that was in 1968, I think it was pretty much decided I was going to be a psychiatrist then. And I have to tell you, I didn't regret it. I've really enjoyed my career. If I was to do it all over again, I'd do exactly the same thing.
Take us back to when you were a little boy listening to your father, watching your father help these patients. Were you eavesdropping? Were you trying to learn? What was your impression at the time?
I don't know. Probably a combination of both. I was a child. So it's just what life was about. If somebody was in need, my father was there for them. And it wasn't a profession. It wasn't a job. It was a way of life. So, if someone called in the middle of the night, then they must need help, and he was there for them. It was a very different profession than what it is now, I have to tell you. And it saddens me to see that the structure of the medical profession has changed. But the world evolves and things have to change. So that's part of it. But no, it's become a much more protective profession. Doctors in the old days in general, particularly in psychiatry, they had the knowledge. Therefore, people went to see the doctor to ask them for advice as to what to do. Nowadays, there are many other sources of knowledge other than the doctors. And it's nearly a different profession that I see we're working with now. It's being affected by many factors. But no, I grew up in a different world. You're right.
Well, you use the term protective. It's more of a protective profession. What did you mean by that?
We are being asked to use guidelines, classifications, labels, follow certain approaches to treatment. And you don't deviate from that, because if you do, it's, you're at your own risk. And it's a pity, because when I started to train in psychiatry, we were taught that every individual with a psychological problem is different. And no two people are alike, and you really got to get to know the person as an individual. All these classifications and labels that we have invented as a profession over the years, in my opinion, have been imposed on us by the profession, by the whatever funding agencies they have. If you don't have a diagnosis, you're not going to get funded. And there are different classifications. And, you're in Vermont and I'm in Cairo. But the world has never agreed on classifications. The earlier studies, even in the 70s and 80s, the way psychiatrists in Europe diagnosed conditions was very different than the US. Numerous WHO studies on that. Nowadays, you're aware, that in North America, people use the DSM classifications, whereas WHO and the rest of the world is using an ICD. But I'm hoping that one day my profession will eventually have the biological correlates or the tests or the scans that we're going to do and see and diagnose schizophrenia with some objective evidence and bipolar disorder. Otherwise, we're going to continue in the dark of debating whether this person has bipolar disorder or manic depressive psychosis. Addiction is going to be another thing. So we'll wait and see how it evolves.
Stigma, it's something you've done a lot of work to reduce. Can you talk about what you've done in that regard, and do you think things are getting better?
They are getting better, not necessarily because of the efforts of us professionals, but the world is becoming more open. I mean, this whole idea of high sort of confidentiality and you don't talk about these things have definitely contributed to stigma over the years. But no, we've run a number of mental health campaigns and in Egypt and I work through the World Federation for Mental Health. And I think objectively speaking, there's a lot more tolerance and acceptance. And also because mental health problems no longer equate psychiatry. I could go to a psychotherapist, I could go to a healer, I could go to a life coach. Traditional healers around the world have forever. They've been taking a big brunt of supporting people with mental illness, whether they're religious organizations or various traditional healers in various societies. And these have contributed to reducing stigma, I have to tell you. And of course, work like what you're doing here is important nowadays. So, 15, 20 years ago, when we were doing a mental health awareness and anti-stigma campaign in Egypt, the internet was not what it is now. And therefore, we had to run ads on television, hugely expensive, going into millions. But it was interesting realizing that, your dollar takes you much further when you're not interviewing doctors. I think service users, societies in general, have heard a lot of doctors talking about mental health. But if you really want to reach people's hearts, get into famous people, maybe famous politicians, heads of states, actors and singers are amazing. If you get a famous actress saying that she has suffered from depression or that her husband has developed dementia, that reaches people's hearts. And even more than artists and singers is football players, certainly in my part of the world.
The term of art, I guess, these days is influencers, and they have more credibility, perhaps, than the authorities, than the people who are in the establishment. So as long as they're speaking about things accurately, I suppose that's all to the good, right?
Yes.
So just sticking with the idea of stigma and protections for folks with mental illness, you've worked on legislation to protect those rights. And I'm wondering what kind of protections you think are still needed. And is a lack of these rights, a global problem, or is it not consistent across the world?
It's different across the world, in different countries, according to the practices of mental health. I mean, individuals with any kind of incapacity need support. You may be familiar with the CRPD and the protection of people with disabilities. That's at one end of the spectrum. But you see, once you start depriving individuals from their freedom, once you start locking people up in hospitals, you've got to be careful because they do not have access or recourse to contact, support, lawyers, families. And in every country in the world, there have been those early 20th century asylums where people had been forgotten there for, decades. And what we did in Egypt in 2009 is that we were able to pass a law that protects these individuals within those institutions. It was an important step forward. Interestingly, it was very well accepted in society and in parliament and in politicians. It was the doctors who were not quite sure what to do with that, because psychiatrists were not very comfortable with the idea of saying, there's going to be a second opinion. There's going to be somebody, the patient will contact their lawyers if they want. And if you're going to deprive them from access to telephone or internet, you've got to state why you're doing that. And is it really to their benefit? And it's an interesting period. Most countries around the world have mental health laws in one way or another, or at least policies that they have. WHO recommends that the countries should review their policies every 5 years. That's setting the bar a bit high, because it's a lot of work and a lot of money to pass legislations. But they need to be reviewed, because attitudes change as well. But it was an interesting exercise that we did. It's got to go hand in hand with your community awareness and anti-stigma campaigns, because you can pass legislations in parliaments, but every country will have laws that are there on the shelves, not being used if the community doesn't really believe in it. But no, we've made a change.
While we're taking a broad look at things globally, there's been a really sharp increase in demand for mental health care in the United States, particularly COVID and post-COVID. And I'm wondering if you're seeing that where you're practicing in the UK and in the Middle East. And at the same time, there's access problems because it's been difficult to get, in the United States anyway, people to go into psychiatry because it's so expensive to get educated, and being a psychiatrist doesn't pay enough to pay off the debts and so forth. So what's that balance like of supply and demand in your view?
It's a reality. Healthcare has become expensive. And I'm embarrassed to say, but we have made it so. We professionals have made it very expensive. We've made the education expensive. We made maintaining the practice expensive, continuous medical education, and the kind of medications or tests that we use. You could tell somebody that they suffer from attention deficit disorder, and that's a clinical opinion. Or you could go and have a whole psychoeducational assessment, hugely expensive, at thousands and thousands of dollars to do it. The whole exercise has become very expensive, and it's gone out of reach of your average citizen. I think the Scandinavian countries were the last countries in the world who the state could provide mental health support, but even they are complaining now. But no country today can really, on a state level, provide or fund mental health care to the standards that we require. It's all very well teaching our trainees that, a psychotherapy session should be 50 minutes. We're a country of about 110 million people, and there are a couple of thousand psychiatrists at the moment. They're not going to spend 50 minutes with it. It's just not going to happen. It's simple mathematics would tell you that. So I think trying to provide mental health support at a low cost is what we ought to be looking at. And I was hoping that international organization, WHO, World Psychiatric Association, and the Federation of Psychiatrists of Mental Health would support that of promoting low-cost mental health care, because the cost of medications. I'm not sure what's happening in the States now, but you really can't get Prozac in most countries around the world anymore. It's gone. It's gone generic. We've forgotten about it. We're just coming up with more and more expensive medicines, and we just can't afford it.
Right.
So we really need to cut down our prices.
So what would a low-cost model look like? How do you get there?
You talk to the pharmaceutical industry. You will know more about that than I do. But, the US is leading the world in psychopharmacology and psychotropic medication. Your Congress has passed a law a number of years back saying that for a company to produce a new medicine, they needn't prove that it's better than the old one. They just need to prove that it's better than placebo. If there was a call to say, look, what is the argument of doing away with an old medication? It no longer exists. It's going to go generic, then it's going to disappear. We're going to get a new one in, and we don't even have to prove that it's as good as the old one. I think that would make a big difference. And also, give some credibility to traditional ways of medicine. You know, it's gotten to a point now that for me to diagnose somebody to suffer from OCD, I need to show that I've actually done the online course that's going to qualify me to do that, and that exists, and it pays so much, and you pay online. And by the time you go to the developing world where people have to find dollars to send to some organization somewhere in the world, so take this course, and it's everything. I've recently had a therapist who had just completed their training in compassionate therapy. I mean, in my lifetime, I thought all psychotherapists were compassionate, but apparently not so. Unless you've done the compassionate therapy course, you're not compassionate. Where are we going? What are we giving to our children? What is the next generation of mental health professionals going to look like? I can't say somebody's suicidal unless I've done the course that qualifies me to. So meanwhile, this person will have to wait until I get the money to do a course so that I can tell them that they're not going to wait. We have to stop this one way or another.
Yeah, an awful lot of bureaucracy and red tape has grown up around medicine, that's for sure. It's the most highly regulated industry in the United States by far. So, I've heard this complaint from psychiatrists before that they feel like they have just become people dispensing medications and not doing much therapy, which is what they were interested in the first place. I want to talk, therefore, about approaches to therapy, and one that you are an advocate for is intensive short-term dynamic psychotherapy. Can you describe that method for those of us who may be unfamiliar with it, and tell us why you think it's effective?
Most psychotherapists I've worked with, regardless of their training, that I've asked them, what school of psychotherapy do you use? They would say, I'm eclectic. I use a bit of this and a bit of that. And I've done all these courses that I've done. So in that sentence of intensive short-term dynamic psychotherapy, I would put 3 lines under short-term. Before I can tell somebody, come and see me once a week for 5 years, and we're going to bring on some changes, I'd better have some good evidence for it. And the truth is that I don't. And again, a matter of cost, a matter of funding, a matter of availability. So we need to develop our intensive short-term therapy. By necessity, this is happening. Your classic psychodynamic Freudian psychoanalytic psychotherapy is dwindling, isn't it? It's just too expensive, and it's fascinating and it's interesting. Once a year at Harvard, there is something called the Arab Weekend in Harvard, and I was invited to talk there because the topic of that particular year was psychotherapy in the Arab world. And we ended up on this panel with this very capable psychologist from the American University in Beirut. So she's representing psychology, I'm representing psychiatry. There was one person who'd experienced psychotherapy and gone through it in the Middle East, and what is now becoming very fashionable, which is online therapy. So there was this gentleman who had started this huge online program extending from the Far East to the Middle East. I think they were seeing thousands of sessions per month. And this psychologist sitting next to me was whispering to me saying, Freud must be turning in his grave. And I think she hadn't realized that she had a mic. She had a little mic on her lapel. And so everyone had, and everyone laughed. and this very smart IT tech person giving the talk on online psychotherapy turned around and he said, yes, but Freud had 10 clients. This he hasn't even remotely touched what we're doing. If you keep doing that, you're not going to go far. You have to move on. So short-term dynamic therapy is where we're heading, really.
And what does that look like? To help people understand, if they were going to a psychiatrist who was using that approach, what would that look like?
Effective and modest aims is what I look at. So rather than saying, come and see me in therapy and I will make a better person out of you, which is a very ambitious and slightly arrogant aim, if you ask me, I'm going to say, look, we're going to work on your agoraphobia, or we're going to work on your relationship with food. And, the fact that you had issues with your parents when you were young, I'm sure could have been one of the contributing factors. But let's get to the target. Let's get to exactly where we want to go. This is going to be much more practical in this world we live in today. It's much more achievable. And by and large, in other disciplines in medicine, I've never gone to see a GP who said, "I'm going to make a better person out of you." Yeah, he's there to treat my symptom, essentially.
Right.
So I think focusing on symptom-targeted help is going to be what is needed, really.
I want to get back to the issue of using technology in providing psychiatric care and psychological support. Obviously, it's taken off like mad, and there's telehealth platforms that people can access. I heard an advertisement the other day, and you have access to 30,000 psychiatrists who had signed up to provide care on that platform. So I'm wondering if, because we spoke before about the lack of supply of psychiatrists, is that a partial answer to that? And what's your perspective on whether that can be an effective approach, an effective modality?
It's a reality. Whether you approve of it or not, the pros and cons to everything. But it's happening, and it's going to happen. And, we can say that I approve or not, or disagree or whatever, but I had a grandmother who one day they told her, ladies around the world are going to wear skirts that show their knees. And she laughed and said, this isn't going to last. No lady wants to show her knees. Knees are not an attractive part of the body. And she dismissed the whole thing as being a fad that's not to last long. Some things happen. And they will.
You can't stop them.
You can't stop them. So I was giving a talk at the British University in Cairo a couple of months ago, and this young psychologist asked me, "Do you approve of psychotherapy using AI?" And I said, "Young lady, it doesn't even matter at all whether I approve or not. It's no one's going to wait for my approval. It's happening, and it's going to happen, and it's going to work. So let's see how we can make it better and safer." But this whole idea of trying to stop the evolution because we're not convinced, we've tried. It doesn't work. So it's different. There are pros and cons to everything. When hospitals started using electronic medical records, I was horrified at the thought that, the ease of breaking into the records and confidentiality. And I've actually slowed it down a lot in the hospital where I managed, been criticized for it terribly. And I regret doing that. Every evolution will have its positive and its negative points, there's no doubt. And online therapy has taken off, and it will evolve. Obviously, I don't need to tell you, the great advantage is accessibility like we've never seen it. One thing I quite enjoy doing is when I see somebody online, and they're often at home, I see their home, I see their background, I see how they treat their kids sometimes, or they shout at their pets. And people generally don't dress up for online therapy. Whereas in my clinics, the ladies go to the hairdresser before coming to see me. You see, it's a different. This is all gone, but I used to love to see patients at home. I used to love to do domiciliary visits. You go to their homes, you talk to their families, they offer you tea, and you spend time together. Now, that, of course, is a luxury that's completely gone. In Cairo, just finding a parking place before you get to somebody's home is a difficult one. So,
well, that's interesting. There could be sort of an old-fashioned dimension to the home visit through virtual technology.
One interesting thing about online therapy, because, of course, this really took off during the COVID lockdown. And when people were locked down, they were locked down at home with their families. But if they were going to talk to their therapist, they wanted some privacy. And not everyone has privacy at home. These are questions you don't ask when they come at the office. But I would have an online appointment with somebody, and it wasn't a rare occurrence. It happened a lot. They go down to their cars and talk to me from the car, because at least they're alone, and their parents or spouses or whatever are not around. So it gives you a feel. No, I find there are some positive things about it, for sure.
A minute ago, you mentioned that artificial intelligence is a fact, and we should just accept that and work to make it safer and better. What is unsafe about the use of artificial intelligence in psychiatry, do you think?
The lack of references. Old-fashioned people who used Google, if they read something, they knew who said it, who quoted it, and when it was written. I don't seem to have that on ChatGPT or Perplexity or otherwise. So one of my clients last month, I think I prescribed a medicine, and he told me, I'm not comfortable, my serotonin is too high. And I said, why do you say that? He says, because I went on ChatGPT and I realized that what this medicine does, it increases the levels of serotonin in my brain. You can't tell them that there's no evidence for that because it's there on AI. So you're losing this battle. So I said, this is extremely helpful, but you're good at these things. Could you please, as we're there, could you check with AI, how do they measure serotonin in a human brain? Because I have no idea how they do. And the truth, of course, is you can't. I mean, So he realized. So I think the problem with psychotherapy and AI is the lack of references that we have. So not in the clinical work, we always have references, but in those psychotherapy, those schools, the Freudian and post-Freudian schools, at least if you were using Carl Rogers' approach or Jungian approach, you had a reference. You said, this is what Jung said.
You could verify it.
But no, AI has done away with that, I'm afraid, yeah.
Yeah, that's a very good point. There are, I think, in medicine, some attempts to limit what it is that AI is looking at,
Yes, but can we control it?
It can only investigate a defined universe of peer-reviewed publications and so forth, and those answers obviously would be more credible than otherwise. Listen, we've taken a lot of your time. I want to, as we wrap up here, we love to give our guests an opportunity to provide some advice because we have an audience of learners and early career professionals. So what is your go-to advice to people entering into a career in medicine and psychiatry?
So yes, that's a very relevant question. Thank you for bringing it up. If I'm going to be able to help individuals within the field of mental health care, I always need to think that it could be me. I could be the one who needs help, or my spouse, or my children, and put myself in the shoes of that person who's feeling desperate, trying to understand their symptoms and be there for them, to tell them the outcome, to tell them what I think of the treatment plan, and also to be perfectly honest with them about the limitations of our knowledge. I think if you're going to help somebody, they need to trust that you're totally transparent about the limits of what is it that my therapy can do. They feel safer with that. I think gone are the days where you go to a doctor or to a therapist and, he knows it all and he can provide 100% treatment. There's no such thing. So transparency and empathy is what I advocate for.
Well, that's wonderful advice to end on. And I want to thank you so much, Dr. Loza, for taking so much time to be with us today. It's been a great pleasure.
Thank you, Michael. This has been a very helpful exercise. You're doing good work to help our communities, and I was happy that I was able to provide some assistance to that.
I'm Michael Carrese. Thanks for checking out today's show, and remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.